Oh, thank you so much, Sanjay. It's great to be here and really delighted to be asked to speak at this conference. And
Alison, we can't
it's,
hear you.
can you hear me? I'm not sure why.
Oh, we've
Yes,
got
we
you.
can. Sorry,
Sorry.
that was our end.
Can you hear me now? Hello.
Yeah.
Yes, brilliant. Thank you.
Okay, sorry. Good. Right. Well, what I was saying was I'm delighted to join the conference today, and it's been a huge privilege to work with Sanjay way back in, I can't even remember what year we started doing this work, Sanjay, but a delightful team to work with to get the Healthier Together resources going. So I've been asked to speak on aligning the NHS and strategies for children with the local authority. So most of you will know that services like health visiting and school nursing sit within the local authority. But by working together, we really do believe that there's huge potential to improve outcomes, and not just with local authority, but obviously the broader remit of voluntary sector as well. Let's move my slides on. I've got technical glitches today. Not sure why they're not doing. Okay. Not sure why my slides aren't moving on. So, oh, here we go. Great, done it. So it's great to be with like-minded people today. So many of you working together with families and children, babies, young people to improve outcomes. And I know it's not easy at the moment. There are huge challenges out there. So I'm not going to ignore the challenges, but also to recognise there are also enormous opportunities by working better together. So my presentation will focus on why we need better integration, why it's needed, and what part do I particularly play in this for all of us. So all the best logic models start with situational awareness, or what's the problem? Why does it matter? To drive change, I used to work at Public Health England. We were told we needed to do it with the evidence. And it's clear we do have a massive problem. So just to set the scene, before the pandemic, we had a poor state of child health in this country. There's nothing to be proud of. Widening health inequalities, soaring costs of late intervention, or some would argue getting it wrong, huge problem with invisible, vulnerable children not known to services, and fragmented child health policy from the top of government right down to local authority level. There have been some incredible achievements during this time, so it's not all bad news. So things like teenage pregnancy has gone down, smoking in pregnancy has also reduced. But overall, most of our metrics are going in the wrong direction. And health visitors have a hugely privileged position because they see what's going on behind families' front doors. They see thousands and thousands of families up and down the country every single week. And these parents and babies are often invisible to other services until they hit crisis point. They see trends long before they land on a minister's desk in the Department of Health. And actually on this slide, I've just put some of the findings from our annual survey. So this was more than 1,300 health visitors across the UK. And what they told us was that families are really struggling. Poverty was the biggest concern facing families. So 91% of health visitors, that's pretty much every health visitor, said they'd seen an increase in families affected by poverty in the last 12 months, alongside a rise in food banks, domestic abuse, and mental health problems. And all of these we know can make parenting much, much harder. And this matters because when parents struggle, it has a direct impact on child health, safety, and development. And what we've seen in our own data, as well as research findings, and also the government's own data that they're publishing on child development at 2, is that a significant and growing minority of babies born in the pandemic have fallen behind with their development. Children from the poorest backgrounds are affected the most. Many of you working in paediatric care will know there's a growing concern about vulnerable children not known to services and late presentations, 2 types of vulnerability: clinical vulnerability, so that's children with special educational needs and complex conditions, as well as safeguarding vulnerability, and some with catastrophic consequences, we know. So as at the same time as need has gone up, we've also had reduced capacity within services to meet the scale of need. This is across all sectors, so community care, primary care, secondary care, and actually for health visiting, despite health visitors' best efforts, so they're seeing thousands of families every week, we know that families are facing a postcode lottery of support. Many are missing out on their routine health checks, so almost 500,000 families didn't receive the check last year. And what that means is for these babies and young children, we know very little or almost nothing, probably for some of them, about them. We don't know about the world they're living in and the concerns that they might have. And actually, health visiting as well has been impacted. So the drop-in clinics that used to be in communities, many have shut down and haven't reopened since the pandemic. And actually, there's no reason for this variation. So we're told that it's local decision making, local areas know best what's fit for their community. But actually, when you look at the key public health priorities for babies, children, and families, they don't vary that much between local authority areas. So the question for me really, and hopefully for everybody, is do we actually want a national healthy child programme? In my view, it's much too important to be left to chance. Most parents can advocate for their babies and young children, but some can't and some won't. We know that some parents will be unaware that their child has got a health problem or a developmental delay, or if their baby is in distress. They might feel stigma and shame. For example, if you have a perinatal mental health problem, it can really take the joy out of parenting and make it much, much harder. But we also know that getting help early can make a big difference. And sadly, we also know that a very small number of parents will deliberately inflict harm on their children. And actually, for those babies and young children, they need a voice. They need professionals out there to be seeing them. So how are we responding in terms of spending? What you spend your money on is the thing that's the most important to you. So what you can see on this slide, on the left-hand side, we can see exponential growth in spending on children's social care since 2017. We now have 4,000 more social workers, and there are more in the pipeline. We're spending more than £23 billion a year on late intervention, and some would call it getting it wrong. At exactly the same time, what we've seen is the public health grant has been cut by more than £1 billion in real terms, and we have 40% fewer health visitors. And this matters because as the pool of health visitors shrink, their work gets harder, and fewer families get the support that they need. Services are reprioritised, and we're just firefighting. There's less prevention, less early interventions, and it's a downward spiral in the wrong direction. So the evidence is absolutely clear. I've talked a lot about problems, but we actually know what the solution is. If services are flooded with need, waiting lists are going up, A&E are full of babies and young children that used to be seen elsewhere, we need a decisive shift upstream. And I often use the analogy of if your bath at home was overflowing and you were flooding the downstairs of your house because you'd left the tap on and the plug in. What would you do? Would you go out and buy very expensive, sophisticated mops and buckets, or would you run upstairs and turn the tap off? And actually, health policy is no different. It's exactly the same. Yet ICSs spend less than 1% of their budget on prevention and early intervention. And the evidence is absolutely clear. We have more evidence than any other generation. If we want to change the story, we need to change the beginning of the story. We need to focus on prevention and early intervention. If we don't do this, if we don't do this properly, if we just tinker at the edges and sticking plasters on this, we need to brace ourselves and the healthcare system and future generations for spiraling costs of healthcare into the future. So there are three critical periods that we need to improve outcomes in when we're thinking about children. We have a policy strapline, which is we give every child the best start in life. It's often focused on the absence of disease. We're building children for something into the future, which will be better for them. And that's really important because we know that the greatest global threats to health are non-communicable diseases, so conditions like cardiovascular disease. They take root in early childhood. They're largely preventable. And as I said earlier, if we want to change the story, we need to change the beginning of the story. So they're important, but we also need to focus on two other areas of life. The first is building strong human beings in the first place, and that's about getting preconception and pregnancy right, reducing risk factors. There's lots of work we can do there. And secondly, we need to value the period of childhood in its own right, see babies and and children as citizens in their own right. And currently in national policy, not enough attention is being given to babies and children, and we need to focus on them for these short, medium and long-term outcomes. And we would argue we need to change the strapline. We need to give every child the best life from the start. So this is where better integration comes in. To improve population health and to reduce inequalities. So we need collaboration, and that's about viewing each partner as complementary. We're not a homogenous group of professionals. We're actually all unique and different. And by celebrating our difference and coming together as a giant jigsaw, we have a huge opportunity to get better outcomes. We need collaboration at three or four levels, you could argue. So firstly, within the NHS, and then between the NHS and the wider healthcare system, so that includes local authority public health. Thirdly, with the voluntary sector working in neighbourhoods and communities and places and systems. And finally, across the life course, babies become children and become young people and then become adults. And we need to map out this journey and integrate across the whole lot. But finally, we need national join-up. So it's all great for local areas to be integrating, but actually we have fragmented national government. So we have multiple child health policies that come out of different departments, Department of Health, Department for Education, DWP. They all have policies for children and very, very little join it. So we do need a better join up at national government as well. And then you're probably very familiar with these four main purposes of the ICS is about improving outcomes, tackling inequalities, enhancing value for money, but also to support broader social and economic development. So taking a whole system approach requires everybody to play their part. So it's important to keep families at the centre. Families are complex people living in a complex world, and we need multiple solutions to get this right. We need to work very closely with community and voluntary sector who do know their local need very well, but not at the expense of statutory services. And I need to make this point very clearly. We actually need robust multidisciplinary teams. So that's midwives, paediatricians, health visitors, GPs, therapists, all coordinated with one shared vision, one shared ambition to improve outcomes for children. And ICSs present this huge opportunity for greater collaboration. We actually know what we need to do. We have a fantastic health policy. It's called the Healthy Child Programme. When delivered effectively, the benefits accrue across the health and care system, into social care and education, and across the life course. We need to prevent, identify, and treat problems before they reach crisis point. The problem is not with the policy. There's great blueprint. The problem is translating the words into action in practice. It's about implementation. So I just wanted to focus on two areas, particularly to bring this to life, where I think ICSs could definitely improve outcomes for children through integration. And the first is supporting children with special educational needs and disabilities. I have a personal disclaimer. The little boy on the right is my son, Sam. He's now an adult. But so I understand what it's like as to be a parent of a child with complex conditions. The scramble of colours in the middle of my slide is a parent that we work with in Hampshire who set out all the different agencies she had to work with her child who had a complex condition. It can be absolutely overwhelming. And we have a problem across the whole clinical pathway, which I put on the slide in prevention. We're not spotting we're not preventing these conditions happening in the first place. As I mentioned earlier, fetal alcohol spectrum disorders, smoking in pregnancy. There's lots of work we can do in prevention. Early identification, we have huge gaps. We're spotting these children much too late. For some children, like children with cerebral palsy, the outcomes can be catastrophic if they don't get treatment early, and transformational if they do. So we need to improve identification of these children. It's also about engaging families. For some families, it's not easy. So that takes effort too, to engage them in services. And then the purple chevrons on this slide is where most people put their eggs, but we can't ignore the ones either side. And finally, the safety netting. The families who need the help the most are the most likely to drop out of services and fall through the gaps between them. So we need a safety net around families to support these children throughout their whole life course to improve outcomes. And doing this actually saves money in the long run, because then we have children reaching their potential. And so we have a huge vested interest economically as well as humanitarianly for these children. The second example is about reducing A&E attendances in under 5. So it's a huge problem. I used to work at Public Health England and wrote the submission for the long-term plan many years ago. And actually, way back in 2017, we'd seen a 24% increase in children's A&E attendances over the previous years. And it's just got worse. So you can see on this slide, this is A&E attendances during the pandemic. So there was a drop during the pandemic, and then it's gone up steep trajectory upwards in pretty much all sites. Children are attending, and actually most of these presentations are for relatively minor or self-limiting illnesses and unintentional injuries. So the solution is multiple. People are complex, and there's not going to be a simple solution for everybody. We need multiple solutions. Parents are attending A&E because it's perfectly normal to worry when your baby is sick. And if you can't get the solution you need elsewhere, then you end up in A&E. So I really want us to shift away from the language of calling it unnecessary A&E attendances. We need to recognise the anxiety in parents, and we need to address this in the solutions. And as the delivery plan report says, the challenge is not just in ambulances or building more and more A&E departments. So neither should the solutions be. And on this side, I've just put the reasons why parents attend A&E. We've just done a deep dive into that. Many reasons. So being seen on the same day, no appointment needed, particularly for families, with a new baby where it's all a little bit chaotic. You haven't got, making an appointment for some families can be a huge struggle, so they turn to A&E for that. Seeing somebody outside of hours. Perception that A&E provides higher quality care. There's a belief that you need a person with a stethoscope around their neck and a machine that bleeps if your baby's sick to tell you whether they're going to die or not. And actually, we can empower parents in a much better way to have the confidence to manage their child's illnesses in the community. Parents have a lack of confidence. They're worried that their child is going to be the one child with a serious illness, and they're a bad parent if they've missed it. And that's again about confidence. They're looking for guidance to manage their child's condition. They're looking to be seen to be doing the right thing, and this is interesting, particularly for families on the edge of social care. And social workers are driving this, I have to say. Sorry, I've got COVID at the moment, apologies. Parents are attending A&E, almost to tick a box to say, look, I'm being a good enough parent, because I've come to A&E, and we shouldn't be feeding that beast. Geography, families that live nearer to A&E are more likely to attend, and also first-time parents are hugely anxious. It's hugely worrying time. So we need multiple solutions. Working with these families, we need accessible support in the heart of communities. And just to plug for health visiting, we need to get back to health visitor drop-in clinics. I mean, they had a massive role to play in communities. We need to support parental health literacy and improve their confidence. And we need consistent, explicit safety netting advice, which is where Healthier Together comes in. So just as I come to a close, we all have, I've just given you a couple of examples. There are loads and loads more that I could share with you. We all have our own unique selling points. So it's by pooling our efforts together we can really maximise our contribution and improve children's outcomes. So as I come to an end, just signposting to a great film we made about health visiting, and I shall hand back to you, Sanjay.